Every month you're doubled over with pain. You're missing work, cancelling plans, lying on the bathroom floor wondering if you're just rubbish at handling periods, because that's what people have hinted for years. And yet, deep down, you know this isn't normal. If that sounds even slightly familiar, stay with me. In this video, we're going to walk through what endometriosis actually is, how it fits into real-life NHS care pathways in the UK, and how to know when it's time to seek GP care, ask for a referral, or even seek urgent help. You'll also hear how endometriosis is different from other common causes of period pain, and what evidence-based treatments the NHS actually uses in practice. Welcome to Balanced Woman UK, where we provide evidence-based women's health information you can trust. Everything in this video is based on official NHS, Royal College of Obstetricians and Gynaecologists, and NICE guidance, and I've linked all sources in the description below. Let's start simple. According to the NHS, endometriosis is where cells similar to the lining of the womb grow in other parts of the body, often around the ovaries, fallopian tubes, or the lining of the pelvis. These patches respond to hormones just like the womb lining does, but the blood has nowhere to go, which can cause pain and inflammation over time. The Royal College of Obstetricians and Gynaecologists, or RCOG, describes endometriosis as a long-term condition that can affect physical health, emotional well-being, and daily life, and it can be present from puberty right through to menopause. Endometriosis is common. Roughly 1 in 10 women and people assigned female at birth are affected. But here's the tricky bit. It doesn't always show on scans. There's no simple blood test, and the symptoms overlap with lots of other conditions. That's part of why diagnosis can be slow and why you might have been told for years that your pain is just bad periods. So what does endometriosis actually feel like day to day? Based on NHS and RCOG information, common symptoms include severe period pain that stops you doing normal activities, pelvic pain in your lower tummy or back that can be present all month, pain during or after sex, pain when you poo or pee, especially around your period, very heavy periods or bleeding through to clothes, fatigue that feels bone deep, and sometimes difficulty getting pregnant. Some people also notice bleeding from the bowel or bladder during a period, which is always a red flag that needs medical assessment. Very rarely, endometriosis can affect the chest, causing chest pain, shortness of breath, or coughing up blood around the time of your period. Lots of people get primary dysmenorrhea. That's the medical term for normal period cramps without an underlying disease. Those cramps usually start a day or two before your period, peak in the first couple of days, improve with anti-inflammatory painkillers and a hot water bottle, and don't typically stop you functioning for the whole cycle. With endometriosis, pain is often more intense and disabling, can last outside your period, and commonly comes with bowel or bladder symptoms, pain with sex, or fertility problems. If you're thinking, that sounds like me, and it's been getting worse over time, that's exactly the kind of pattern the NHS says should prompt a GP review. Endometriosis isn't the only explanation for bad cramps, and within the NHS care pathway, your GP will also consider other conditions with overlapping symptoms. Adenomyosis is one, where tissue similar to the womb lining grows within the muscle of the uterus itself. It can cause very heavy, painful periods and an enlarged, tender womb. Fibroids are another very common cause. These are non-cancerous growths in or around the womb that can lead to heavy bleeding, pelvic pressure, and pain. Pelvic inflammatory disease, or PID, is an infection of the reproductive organs, often linked to sexually transmitted infections. It can cause pelvic pain, fever, abnormal vaginal discharge, and pain during sex. PID is a medical urgency because untreated infection can damage fertility. Some people get IUD-related cramps, especially in the first few weeks or months after an intrauterine device is fitted. Mild crampy pain can be expected, but severe persistent pain or pain with fever or heavy bleeding needs a GP or urgent review. And then there's primary dysmenorrhea. painful periods without an underlying condition, especially in younger people, which often respond well to NSAIDs and hormonal contraception. GPs are trained to keep an open mind, so if you mention, "I'm worried about endometriosis," they'll also be checking for these other causes in line with NHS and NICE guidance. Let's walk through what usually happens if you see your GP in the UK with suspected endometriosis-type symptoms. This is based on NHS guidance and the NICE guideline, Endometriosis, Diagnosis and Management, NG73. First comes the GP consultation. Your GP will take a detailed history of your symptoms, when they started, where the pain sits, how it links to your cycle, and how much it affects your work, school, or relationships. They'll ask if any close relatives have endometriosis or similar conditions. They may offer an examination of your tummy and an internal vaginal examination, always with your consent and with the offer of a chaperone. They may arrange blood tests, especially if your periods are heavy and there is a risk of anemia, and they might offer first-line treatment like NSAIDs and hormonal contraception even before a formal diagnosis. This sort of trial of treatment is supported by NICE. If your GP suspects endometriosis or another pelvic condition, they may refer you for initial tests such as an ultrasound scan, either over your tummy or internally, to look at the womb and ovaries. Sometimes, if deeper disease is suspected, an MRI may be considered later on. It's important to know that a normal ultrasound or MRI does not rule out endometriosis. Both NHS and RCOG are very clear that endometriosis can be invisible on imaging, especially smaller patches. If your symptoms are severe, persistent, or not responding to initial treatment, your GP can refer you to a gynaecologist. Under NICE guidance, this may lead to further imaging and a discussion about a laparoscopy, keyhole surgery, where a camera is inserted through the abdomen to look for and often treat endometriosis. Laparoscopy is still the gold standard for confirming endometriosis, but NICE and NHS guidance say it does not have to be the first step, especially if your symptoms improve with treatment. If you have suspected deep endometriosis involving the bowel, bladder, or more extensive disease, you may be referred to a specialist endometriosis centre. There, a team may include a gynaecologist, colorectal surgeon, urologist, pain management specialists, and specialist nurses. This is all in line with NICE NG73 and RCOG information, and it's exactly the kind of pathway many UK patients experience, although waiting times can vary by area. If you're wondering whether you actually need to book an appointment, use this simple checklist based on NHS advice. You should see your GP if your period pain is severe enough to stop you from doing normal daily activities, if you need to take days off work, school, or caring responsibilities most months, if you have heavy periods, for example, changing pads or tampons every 1 to 2 hours or leaking through to your clothes, if you have pain during or after sex, if you have pain when you poo or pee, particularly around your period, if you're struggling to get pregnant and also have pelvic pain, or if you've tried over-the-counter pain relief and heat and it's still not enough. When you go, it really helps to track your symptoms for at least 2 to 3 cycles beforehand. Note your pain scores out of 10, when in your cycle the pain happens, any bowel, bladder or sexual pain, and how it impacts your work, study, relationships or parenting. Note any family history of endometriosis, fibroids or similar conditions. You're not being dramatic by doing this. You're giving your GP exactly the kind of structured information NHS and NICE guidance rely on, and it makes it easier for them to decide on the next steps with you. Now let's talk red flags. There are times when you shouldn't wait for a routine GP appointment. In the UK, you can call NHS 111 for urgent advice if you're not sure what to do. You should use NHS 111 or seek urgent medical advice if you have sudden, severe pelvic or abdominal pain that is different from your usual pattern. If you have pain with fever, feeling very unwell or vomiting. If you have pain with fainting, dizziness or shoulder tip pain. which can suggest internal bleeding. Or if you have very heavy vaginal bleeding, soaking through pads every hour or passing large clots. You should call 999 or go to A&E if you have severe, sudden pain and feel faint, breathless, or like you may collapse. Or if you have chest pain, shortness of breath, or cough up blood, especially around your period. This last situation is rare, but can be a sign of endometriosis in the chest or another serious condition. These symptoms don't automatically mean endometriosis. They can be ovarian torsion, ectopic pregnancy, a severe infection, or something else entirely, but they all need urgent assessment. So what can be done if you do have endometriosis, or if your GP treats you as if you might have it? NHS, RCOG and NICE guidelines all line up on the main treatment options. They're usually tailored to how severe your symptoms are, whether you want contraception, and whether you're currently trying for a baby. First, pain relief. The most common first-line medicines are anti-inflammatory painkillers like ibuprofen or naproxen. These help with pain and can reduce menstrual blood loss by around 20 to 50% in some people. Paracetamol can be used alone or with an NSAID if you can't tolerate high doses of anti-inflammatories. If pain is severe or long-term, stronger pain medicines and neuropathic pain treatments may be considered under specialist guidance, often as part of a wider pain management plan. Second, hormonal treatments. These aim to reduce or stop periods, which often eases pain and inflammation. Combined hormonal contraception, the pill, patch, or ring, is commonly used, often taken continuously without the usual hormone-free break to suppress periods. Progestogen-only methods, such as the levonorgestrel-releasing intrauterine system, or LNG-IUS, the mini-pill, injections, or the implant, are another major option. The LNG-IUS is recommended by many NHS services as it can significantly reduce bleeding and pain and also provides long-term contraception. In more complex or severe cases, other hormonal options like GnRH analogues or antagonists may be used. These create a temporary medical menopause and are usually given for a limited time with add-back hormone replacement to reduce side effects. Most of these treatments are contraceptive, so they're not used if you're actively trying to conceive. Third, surgery. Surgery is usually considered when pain is severe or persistent despite medical treatment, when there are endometriosis cysts on the ovaries, when deep endometriosis is affecting bowel or bladder, or when fertility is affected and surgery might improve the chances of conception. Laparoscopic surgery can remove or burn away visible patches of endometriosis, remove ovarian cysts, and release adhesions, scar tissue. In more severe cases, hysterectomy, which is the removal of the womb with or without removal of the ovaries, may be discussed. This is a major decision, usually considered only after careful counselling, particularly if you're younger or haven't completed your family. Using a hot water bottle or heat pad on your lower tummy or back can ease cramps. Taking NSAIDs such as ibuprofen with food, if they're safe for you, can reduce both pain and bleeding. Gentle movement or stretching, even short walks, sometimes reduces cramping. Prioritizing sleep and rest around your period, especially if your pattern is predictable, can help you cope. Planning lighter days at work or study where possible around your worst pain days can make life more manageable. Emotional support also matters. Support groups like Endometriosis UK, counselling, or talking therapies can all help you cope with the emotional load of a long-term condition. But it's important to be clear about what self-care can't do. It cannot diagnose endometriosis. It cannot replace medical assessment if your pain is severe, getting worse, or affecting your life. It cannot treat infections like pelvic inflammatory disease or manage heavy bleeding that causes anemia. If you find that self-care measures aren't touching the sides, or you're relying on painkillers most days just to function, that's your cue to move up the pathway and speak to your GP. Clinicians are encouraged by RCOG to listen to the impact on your life, not just whether you're managing to turn up. Let's pull everything together into a clear plan so you don't leave this feeling overwhelmed. Step 1 is to track your symptoms for at least 2 to 3 cycles. Note your pain scores out of 10 when the pain happens in your cycle, any bowel, bladder or sexual pain, and particularly how this affects your daily life, missed workdays, cancelled plans, disrupted sleep. Step 2 is to book a GP appointment and take those notes with you. Be honest about how bad it really is. Don't minimize it to be easy. If you're worried about endometriosis specifically, it's absolutely fine to say that and to mention that you've read the NHS and NICE information. You might say something like, "I've read the NHS guidance on endometriosis and the NICE guideline NG73. My pain is affecting my daily life most months. Could we talk about hormonal options or a referral to gynaecology?" If you don't feel heard or your concerns are brushed aside, you are entitled to seek a second opinion by seeing a different GP in the practice, asking about local gynaecology services, or finding out whether there's a specialist endometriosis centre in your region. Using reputable resources like NHS.UK, RCOG and NICE to back up your questions can also help you feel more confident. Finally, look after your mental health. Living with chronic pain is exhausting and can be isolating. If you're feeling low, anxious or worn down, that matters just as much as the physical symptoms. Your GP can refer you to mental health and pain management services. Many NHS pain services use a combined approach involving medication, physiotherapy, and psychological support to help you cope. If you've recognized yourself in this video, the missed events, the hot water bottle as a permanent accessory, the quiet panic that something serious is being overlooked, I want you to hear this clearly. You are not overreacting, and you are absolutely allowed to ask for proper assessment and evidence-based treatment. Endometriosis is real. It's common, and within the NHS, there is a care pathway, from GP review to gynaecology to specialist centres where needed, built on solid guidance from NHS.UK, the Royal College of Obstetricians and Gynaecologists, and NICE. Your job is not to know all the answers. Your job is to notice the pattern, speak up, and keep advocating for yourself until you're taken seriously. Now, watch this video next on painful periods when it's time to see your GP, because not all painful periods are endometriosis.